Hello everyone. Today I'm Dr. Shlaka. Today I'm starting the first lecture of how to pass the radiology rapid reporting exam. Today I'm gonna do a quick approach how to look at the adult chest cases. Um, I prefer starting with the abdomen, looking for any of these findings, either pneumoperitoneum in an abnormal place like pneumobilia, which is like more central, or portal vein gases, which are more peripheral. Look for any calcification projecting over the liver, like gallbladder stones, like porcelain gallbladder, even like calcified hydatid and any calcified hepatic lesion. You should check for any calcification of chronic pancreatitis, especially if the sufficient part of the abdomen is included in the study. Also, you check for calcification, the renal calcification, the adrenal calcification, and finally, you check for any foreign body. I do have sufficient examples of these findings. Like, let us start with the first example. In this case, as you can see, there is tubular radiolucency projecting over the central part of the liver. So this is in keeping with pneumobilia. More peripheral distribution of the gases are suggestive of portal vein gases. So it's going to be like quite tricky, like in the rapid reporting, like you get this case and you start checking the chest, the blah, 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 and you will forget about checking the abdomen. So please start with the abdomen. Something like this case, you can see there is a calcified lesion projecting over the liver, which is proven to be a porcelain gallbladder. As you can see in the next example, this is a foreign body in the proximal intestine. And as you can see in the next case, there is air under the right diaphragm in keeping with the pneumoperitoneum. You can see here the classical calcification of the adrenal glands. I know, like, this is an abdominal film, but just imagine if it was like a chest X-ray and they've included this part of the abdomen. Okay, so we're done with the abdomen. The second thing is to check the axial skeleton. A lot of stuff to check in the axial skeleton. Let's just go directly to the example. Okay, so in this case, like you check at the abdomen, there is no gases, no abnormal calcification. Okay, no free air. Okay, after that you go to the axial skeleton. The first thing to check in the axial skeleton is to make sure that the shape of the vertebral bodies are normal. As you can see here, especially this vertebra and this vertebra and this vertebra and this vertebra is H-shaped vertebrae. And there is a differential diagnosis of the H-shaped vertebrae, but the most common cause of this is sickle cell anemia. Okay, with the sickle cell anemia also you're going to see like splenic atrophy, sometimes some airspace opacification in the acute chest syndrome, and some avascular necrosis of the humeral heads. The second thing is to look for any abnormal, like the segmentation abnormalities of the vertebra. As you can see here, like some vertebrae, some butterfly vertebrae. So this is very important. The third thing to look at is the evidence of discitis. So make sure that you see like a nice disc space and there is no paravertebral collection. As you can see, this case there is a paravertebral collection, and the case is proven to be tuberculous spondyloarthritis with a paraspinal, with like Pott's abscess, with the paravertebral abscess. Next is to evaluate the density of the vertebral column. As you can see in this case, there is a generalized increased density of the vertebral column, and there is a huge list, like a very long list of causes of increased density of the vertebrae. Next in the list is to check the vertebral body height. If there is any collapse of a vertebra, we call that a vertebra plana, and there is a differential diagnosis of vertebra plana. Okay, once you finish the vertebrae, go and check the clavicles. Firstly, like present or absent, because like if it's absent, it is like part of the cleidocranial dysostosis complex. Is it fractured? Especially check the lateral 1/3 of the clavicles. If there is resorption or erosion of the clavicles, especially the lateral 1/3, and check is it unilateral or bilateral, because they are cause of resorption like rheumatoid arthritis, pycnodysostosis, cleidocranial dysostosis, systemic sclerosis, a lot of causes of clavicular erosion. Try to follow the ribs and see if there is any lytic lesions, sclerotic lesions. It localizes diffuse sclerosis and expansion, to think about Paget disease. Don't forget please to check for the acromioclavicular dislocation. So here are the examples, like this X-ray, you can easily maybe miss the absence of the clavicle. So like to write here, bilateral absence of the clavicles, highly suggestive of cleidocranial dysostosis. In this case, you can see the erosion and the resorption of the lateral 1/3 of the clavicles. In this case, you can see the lateral 1/3 fracture of the left clavicle. And you should be precise when you describe like which side, laterality, and medial 1/3, middle 1/3, lateral 1/3. And you can see here the acromioclavicular joint dislocation. Again, here you can see like sclerosis and expansion of the clavicle. Okay, so like regarding tumors involving the clavicle, mostly metastasis from prostate or breast cancer, primaries, like the most common malignancy arising from the clavicle is the osteosarcoma. Other tumors involving the malignant tumors like lymphoma, benign stuff arising from the clavicle like osteomas, osteochondromas, and etc. etc. Okay, check the ribs. Firstly, start is there any cervical rib, riblytic sclerotic lesion, expansion of the rib notching, especially inferior rib notching. As I said, like rib expansion, rib fractures, and if there's a fracture, make sure it's not a part of flail chest. And finally, make sure that you are not forgetting pictus excavatum. Here, that's the first rib, and that is a cervical rib on the right hand side. As you can see, like expansion and sclerosis of the ribs along with the paravertebral mass. So findings are in keeping with extramedullary hematopoiesis. As you can see, the orientation of the posterior ribs are more horizontal and the anterior ribs are more vertical with blurring of the right cardiac border. These findings are in keeping with pictus excavatum. As you can see, like sclerosis and expansion of the rib. Differential diagnosis is quite long, like it could be Paget disease, it could be metastasis, or as in this case, it could be melanostosis, okay, like that flowing ossification. In this case, it's clearly there is an inferior rib notching in the corcutation of the aorta. In this case, look at the fractures, multiple fractures, and this is flayed chest, okay, because like two sites of fracture in 3 or more consecutive ribs. Okay, after finishing the ribs, the anterior and the posterior ribs, please check the shoulders and the proximal humerus for any evidence of shoulder dislocation, fractures, and you should comment, okay, is the fracture like pathological fracture or not. Don't forget an avascular necrosis of the humeral heads, and there's something quite tricky, which is the congenital elevation of the scapula. We call it springle deformity. So as you can see here, there is a fracture involving like the proximal humeral shaft on the right hand side, along with dislocation of the left shoulder, anterior dislocation of the left shoulder. Okay. In this case, it's quite tricky. Okay, there is a fracture, as you can see, like even there's a displaced fragment here, like a fracture of the proximal humerus on the left side. As you can see here, the clavicle on the left side, it's sorry, not the clavicle, the scapula on the left side is elevated as compared with the right side. So this is a springal deformity. It could be associated with a Klippel-Feil disease, which is like a congenital multilevel fusion of the vertebral bodies. Okay. After that, just check this chest wall soft tissue, like multiple masses in case of neurofibromatosis. This is very important. Absent breast shadow and soft tissue calcification. As you can see, this is a very well-known case in the rapid reporting, like multiple soft tissue masses projecting over the chest wall bilaterally, extending to the upper part of the abdomen. Findings are in keeping with the neurofibromatosis. You can see here some soft tissue calcification, and this is like rice grain pattern of soft tissue calcification. This is typical of cysticercosis, but you can find any pattern or any type of soft tissue calcification, like an extensive cloud-like soft tissue calcification here and here. It could be secondary to tumoral calcinosis, maybe like there is a history of fracture, and the calcification is going to be related to that fracture. Any type of calcification, any soft tissue calcification. Tracheal lesions, don't forget please to check the trachea, especially in peds. I'm not including the pediatric chest radiographs in this video, because like narrowing of the trachea in peds, like we're gonna start thinking about croup with a stipple sign. But even in adult, don't forget to check for any tracheal narrowing or any tracheal mass, and there is a very large differential diagnosis for that, starting from papillomatosis, adenoid cystic adenoma, narrowing secondary to intubation, narrowing related to Wigner's granulomatosis, and so on. Mediastinum, the first question is you should know how to differentiate mediastinal lesions from lung pathologies. Okay, so it's clearly like the lesion forms obtuse angle with the lung tissue, and it is well circumscribed laterally. So this is mediastinal lesion, and as you can see, the mediastinal vessels are clearly visualized through the mass, indicating that the mass is either anterior or posterior mediastinal. We call this like a Highland overlay sign. But if the mass obscures the cardiac border, it is most likely to be anterior mediastinal. And you know, like the 4T approach of anterior mediastinal pathology: teratoma, thymoma, cerebral lymphoma, and retrosternal goiter. Okay. This case is again mediastinal lesion with the same stuff, like forming obtuse angle with the adjacent lung tissue, and there is a sign called thoracoabdominal sign. If the mass is mediastinal and extend into the chest and below the diaphragm, it's in the posterior mediastinum. So this is a posterior mediastinal lesion because of the thoracoabdominal sign. Again, this is the lesion in the mediastinum because of the previously mentioned radiological features, and now the lesion doesn't obscure the cardiac border. So if the lesion obscures the cardiac border, it's in the anterior mediastinum. The lesion doesn't obscure the cardiac border, so the lesion is in the posterior mediastinum, and this case is proven to be like a large neurogenic tumor. Another sign indicating a posterior mediastinal lesion is the cervicothoracic or thoracocervical sign, like any well circumscribed lesion extend above and below the clavicle, and the lateral borders are well circumscribed. The lesion is in the posterior mediastinum, so we call it thoracocervical sign. Okay, after that we are still in the mediastinum. This is a very well-known rapid reporting case, like this is a large radiolucency projecting behind the heart, and it's apparently continuous with the abdomen, this is a hiatal hernia. But if they ask you like in the oral exam, what's the differential diagnosis? It could be gastric valvulus, it could be large epiphrenic diverticulum. Another well-known rapid reporting case, you can see like there is a large like mass or like widening of the diaphragm. It's continuous widening of the mediastinum, which is continuous with the upper abdomen, along with absence of the stomach bubble, and it usually takes this curvature like from left to right, and you can even see the food debris. So this is achalasia cardia. Okay. The other stuff in the mediastinum is air in the mediastinum. Okay, you can see like the radiolucency encircling the heart, and this is a well-known sign, a continuous diaphragm sign. Like we don't usually see the diaphragm behind the heart, but you can see like you can draw the diaphragm, the left diaphragm, and it's continuous with the right diaphragm. This is a continuous diaphragm sign indicating a pneumomediastinum. Okay, after that we go to the heart. Firstly, we should comment on the size of the heart. Like, is it like enlarged or not? Because sometimes, like, if it's a four-chamber enlargement, it's really difficult to differentiate this from the pericardial effusion or the tamponade. If there is a chamber enlargement, especially the left atrial enlargement, very important. They do like this in the rapid reporting. The side of the aortic arch. It's like normally left-sided or right-sided arch, or even double aortic arch. Check for any pericardial calcification, any focal bulging in the cardiac contour, indicating myocardial aneurysm or aneurysm in the aorta, and obviously don't forget to comment on the side of the heart, like it's on the left-hand side and the right-hand side in the dextrocardia cases. In dextrocardia, you should always check the lung. If there is associated bronchiectasis, it could be as a part of Cartagena syndrome. As you can see here, the aortic arch is on the right side. This one is like a double aortic arch. And you know these patients, they can present with adenophagia. We're going to discuss maybe later the vascular rings and slings. As you can see here, like there is a widening of the carina angle. It's usually like about 60 degrees. Like here, it is large carina angle and straightening and even bulging of the left cardiac border, and there is a double shadow sign. All of these findings are suggestive of left atrial enlargement, and you know obviously the most common cause of the left atrial enlargement is the mitral valve disease, especially the mitral stenosis. Whenever you see cardiac pathology, you should comment on the signs of pulmonary edema, which is going to be discussed later. As you can see here, if you follow the arch of the aorta, it is markedly enlarged and even is like pushing and displacing the trachea to the right side. So this is an aortic aneurysm. This is a focal bulging of the left cardiac border, suggestive or diagnostic of ventricular aneurysm. When you do your reading in the cardiology, you should differentiate the true and the false ventricular aneurysms. As you can see here, like there is a previous sternotomy and open heart surgery, and here there is a pericardial calcification suggestive of constrictive pericarditis. And even like if the patient presents with unexplained heart failure with normal size or small sized heart, you should think about constrictive pericarditis. As you can see here, like the flask-shaped heart. Okay, mostly pericardial effusion, but you can do an echo or sonar the patient and angulate the probe to the epigastric area to check is it like a fluid or the heart is enlarging. This is dextrocardia, and as I said, you should check the lung to see if there is associated bronchiectasis to know is it like part of Cartagena syndrome or not.